Your surgery is coming maybe in a few days, maybe before the sun sets today, and underneath the calm you've been carefully rehearsing for everyone around you, underneath the hospital bracelet and the stack of consent forms, there is a question sitting quietly in the back of your throat that you haven't let yourself ask yet. What is genuinely going to happen to me once I'm inside that room? Not the version they hand you in a pamphlet, not the reassuring summary from the nurse who barely had time to make eye contact. The unvarnished version, the one that includes the parts most people instinctively avoid. I'm Dr. Laura, and I've spent 15 years as an anesthesiologist doing something that, when you actually pause to think about it, is among the most philosophically and medically staggering things one human being can do to another. I chemically disassemble your consciousness, sustain your body through an interval in which other surgeons work inside it, and then I rebuild what I took apart. I have done this thousands of times, and I'm going to walk you through precisely what that looks like, not to unsettle you unnecessarily, but because you came here for the honest version and you deserve to have it. So let's begin where your fear probably does. The question you've been half afraid to search. Is it possible to wake up during surgery to be aware, present, fully conscious, and completely unable to communicate that fact while someone is operating on your body? The answer is yes, and the condition has a name: intraoperative awareness. It is exactly as disturbing as it sounds. But there is a number I want you to hold on to tightly. It occurs in somewhere between 1 and 2 patients per 1,000 procedures, which translates to a rate of roughly 0.1 to 0.2%. Statistically, you are more likely to be struck by lightning at some point across the full span of your life than you are to experience consciousness during anesthesia. I'm not offering that statistic to minimize or dismiss the risk when awareness does occur. The accounts patients give are genuinely traumatic. Immobility, the inability to speak or signal distress, the presence of sound and sometimes physical sensation, a complete and terrifying inability to reach the people in the room, but the number matters, and I want you to have it. We have protocols designed specifically to prevent this: real-time monitors tracking the electrical activity of your brain, precision dosing of multiple agents working in concert. Medicine, however, is not perfect, and I believe you are owed that acknowledgement. Now let me take you into the room itself. The operating theater is cold, deliberately cold, because bacteria reproduce more slowly at lower temperatures, and a slower-moving bacterium is a safer patient. The lights positioned above the table are almost aggressively bright. They are engineered to eliminate shadow entirely, because shadow inside a surgical field is a liability. I am standing beside you. I have already reviewed everything that matters about your particular body: your history, your current medications, your allergies, the medical details that shape what happens next. And I am about to do something that still strikes me, even after the 1,000th time, as genuinely extraordinary. I am going to turn off your consciousness, not reduce it, not quiet it, not ease it toward sleep, but extinguish it. That seamless, continuous sense you carry of being a person in a body moving through time, I am going to chemically eliminate it, and when the surgeons have completed their work, I am going to bring it back. If that doesn't land as remarkable, you haven't sat with it long enough. Here is what the sequence looks like, step by step. Before induction even begins, I typically administer what is called pre-medication, most commonly midazolam, a benzodiazepine in the same family as drugs you've probably encountered before. It accomplishes 2 things simultaneously. It reduces anxiety, producing a sense of detachment and calm. And this is the part patients don't always fully register that they're consenting to. It induces anterograde amnesia, which means your brain stops forming new memories. You may speak to me. You may laugh at something a nurse says. You may sign additional paperwork. And later, in recovery, when you try to reconstruct the timeline, none of it will be retrievable, not faded, but absent, as though the recording was switched off entirely. Then comes induction. I ask you to breathe deeply, pure oxygen rather than room air, a step called pre-oxygenation. Within roughly 60 seconds, you are going to stop breathing on your own, and I need your blood oxygen levels saturated enough to give me a safe working window while I secure your airway. You breathe in. The oxygen loads into your system. And then I push propofol through your IV. Propofol is white. It actually looks like milk, which is why we call it milk of amnesia, a phrase that sounds almost gentle for something that does what it does. As it travels up your vein toward your heart, it activates pain receptors along the vessel wall. Patients routinely describe the sensation as fire moving up their arm. That description is accurate. It is also entirely harmless, no tissue damage, no lasting effect, but you won't have long to register it, 8 to 10 seconds. That is all it takes from the moment of injection to the moment you are gone. Your eyes roll back, the tension in your body releases, your breathing stops, and you are no longer there. When I say gone, I mean it in the most literal sense I have available to me. You are in a state that is clinically adjacent to death. Your consciousness has been extinguished, and the full responsibility of keeping you alive now rests entirely with me. Here is something I want to tell you that should unsettle you intellectually. Even if what follows ultimately reassures you, we do not fully understand how anesthesia works. We know what it does. We can watch it on imaging, track the suppression of neural activity, observe the silencing of brain networks, but the actual mechanism, the molecular and neurological process by which these drugs extinguish consciousness, remains genuinely unsolved. It is one of the most compelling open questions in all of neuroscience. The leading hypothesis is that anesthetic agents disrupt communication between brain regions. The prefrontal cortex, which manages awareness and integrates sensory information, becomes effectively disconnected from the broader network. Your brain does not go silent, it fragments. Individual regions continue firing in isolation, but the coordinated, synchronized activity that generates subjective experience, the sense of being you, in a place, at a moment in time, disappears. Where it goes, nobody knows. Whether goes is even the right word, nobody knows. Back to you on the table. You are no longer breathing, so I am breathing for you. Mask and bag valve, manually pushing oxygen into your lungs, watching your chest rise and fall, reading your monitors continuously. Oxygen saturation, heart rate, blood pressure, all of them shifting the instant you lost consciousness, all of them expected, all of them mine to manage. I now secure your airway for the full duration of the procedure through intubation. I open your mouth, insert a laryngoscope, a curved metal instrument with a light at the blade, and use it to visualize your vocal cords, then thread a plastic endotracheal tube down through those cords and into your trachea. I inflate a small cuff on the distal end to hold it in place. Listen to both lungs to confirm correct positioning, and connect the tube to a mechanical ventilator that will breathe for you precisely, consistently, without fatigue until the procedure ends. I also administer a neuromuscular blocking agent, typically rocuronium or succinylcholine, depending on the specifics of the case. These drugs interrupt the signaling pathway between your nervous system and your muscles. Your brain can issue whatever commands it wants. Nothing responds. This eliminates reflexive movement during surgery. Even deeply unconscious patients can produce involuntary muscular reactions, and when a surgeon is working inside your body with a blade, that cannot be permitted to happen. So here is where you are, unconscious, paralyzed, ventilated, entirely dependent on the person standing beside you. That person is me, and I am doing nothing else. I want you to understand what that means. I am not documenting at a corner workstation. I am not in a sidebar conversation with anyone in the room. I am not looking at my phone. I am watching you. I am monitoring your end-tidal CO2, your tidal volumes, your airway pressures, your oxygen saturation, your cardiac rhythm, your blood pressure, your temperature, and the processed electroencephalographic signal that tells me the depth of your anesthetic state. I am listening to your breath sounds. I am watching the color of your skin and the moisture of your mucous membranes and the size of your pupils. Every few minutes, I am cycling through a complete internal checklist. Is this patient stable? Is the anesthetic depth appropriate? Is there anything I am observing right now that I was not observing 2 minutes ago? Anesthesia causes vasodilation. Your blood vessels relax. Blood redistributes toward the periphery. Your blood pressure falls, and if it falls beyond an acceptable range, I administer vasopressors to bring it back. If your heart rate drops below threshold, I may give atropine. If it climbs too high, I reach for a beta blocker. I am making micro adjustments continuously, keeping your physiology inside a narrow corridor of safety while the surgical team executes their work. And what are you experiencing while all of this is happening? Nothing. Not sleep. Sleep is a neurologically active state. Your brain cycles through stages, generates dreams, shifts constantly between patterns of activity. Under adequate anesthesia, none of that occurs. The level of brain activity required to produce a thought, a dream, a sensation, a sense of time passing, it has been suppressed below the threshold at which it can manifest as experience. You are not somewhere peaceful, waiting. You are not dreaming. You are not subjectively existing at all. There is simply an absence. Some people find that comforting, a gap in time, a blink, nothing to endure or get through. Others find it philosophically disturbing in a way they have difficulty articulating. I understand both responses completely. It is not nothing in a trivial sense. It is the temporary cessation of the process that constitutes being a person. Whatever your beliefs, that is worth sitting with for a moment. Then comes emergence. The surgeon is closing. The work is complete. And now I begin reversing what I constructed. I discontinue the inhaled anesthetic agent. I taper the intravenous components. I allow your body to begin metabolizing what remains. Brain activity begins rising from the floor. You are transitioning from pharmacological unconsciousness back toward awareness, but you are still intubated, still paralyzed, and this interval is one of the most technically delicate of the entire case. I need you awake enough to breathe spontaneously and maintain your own airway, but I cannot remove that tube until I have confirmed you can do both. Removing it prematurely risks aspiration stomach contents entering the lungs, and the consequences can be severe. So I watch. I talk to you. I ask you to squeeze my hand, to open your eyes, to take a breath. I am looking for the responses that tell me the lights are genuinely coming back on. When I am satisfied, I administer a reversal agent Sugammadex or neostigmine to neutralize the neuromuscular blockade. Your muscles reactivate, your respiratory effort returns. I deflate the cuff and remove the tube. You cough, you may gag, your face may contort in a way that looks distressing. This is normal, involuntary, and brief, and you will almost certainly have no memory of it. The minutes that follow vary considerably between patients. Some emerge peacefully, blinking slowly, mildly disoriented but oriented within seconds. Others emerge combative, pulling at IV lines, thrashing, not recognizing where they are, not responding to reassurance, a state we call emergence, delirium, which is unsettling to witness and frightening to experience, but almost always self-resolving within minutes. Your brain is rebooting after a significant chemical intervention. Give it a moment. You are moved to the PACU, the post-anesthesia care unit where specialized nurses take over your monitoring. You are on supplemental oxygen. Your vitals are being tracked continuously. Over the next 1 to 2 hours, the pharmacological haze fully lifts and you reemerge into yourself, your name, your relationships, your life, the fact that you just had surgery. But before I finish, I want to tell you about something that exists at the boundary of what I can explain. Some patients return from more extreme circumstances, cardiac arrest under anesthesia, clinical death with full resuscitation, and they report experiences, perceptions of light or peace, or presence, encounters with people who are no longer alive, a sense of having been somewhere else entirely and being told it was not their time. I had a patient routine procedure, cardiac arrest, 8 full minutes of resuscitation including chest compressions, epinephrine, defibrillation, who came back and told me, quietly and without any performance, that he had been somewhere else, that his father, dead for 11 years, had been there with him, that he had been told to return. Was it real? Was it a dying brain generating comfort through familiar imagery? Was it hypoxia producing something that felt like vision? I am a physician. My entire professional life is built on evidence, mechanism, and reproducible outcomes, and I genuinely cannot tell you. What I can tell you is that he believed it without hesitation and that he returned from it changed, less frightened of certain things, more present in others. Whatever it was, it left a mark on him. And it left a mark on me. I have been in that room for many patients over 15 years. I have watched monitors go flat, and I have watched them come back. I do not have a tidy answer for what consciousness is, where it resides, or what happens to it when we extinguish it, and neither does anyone else, including the researchers whose entire careers are dedicated to finding out. Now, let me give you the numbers on risk, clearly and honestly. Death attributable to anesthesia in an otherwise healthy patient undergoing a routine procedure is extraordinarily rare, in the range of 1 per 200,000 to 1 per 300,000 cases. To give you a frame of reference, the drive to the hospital carries a statistically greater mortality risk than the anesthesia you will receive there. That said, risk increases meaningfully with comorbidities, significant cardiac or pulmonary disease, advanced age, obesity, poorly controlled diabetes, and we assess all of it carefully, adjusting our technique accordingly. Short of death, complications are more common. Allergic reactions ranging from mild to anaphylactic, hemodynamic instability, postoperative nausea and vomiting, throat soreness from intubation, cognitive changes in elderly patients that can persist for days or weeks, and the rare but real occurrence of awareness. We are prepared for all of it, not theoretically, but through rehearsal, drilling, and embedded protocol. I have been doing this for 15 years, thousands of patients. The weight of it has never left me, and I don't want it to. Every time I induce someone, I am accepting full responsibility for a life. Not partial responsibility, complete responsibility. If I am inattentive at the wrong moment, you die. If I miss a warning sign, you suffer a preventable complication. The stakes in that room are absolute. People ask me whether I am ever afraid, whether I ever doubt what I'm doing. The honest answer is yes, not in a way that compromises my performance, but in a way that sharpens it. The day I walk into an operating room and feel nothing, no weight, no acute awareness of what is at stake, is the day I should not be there. That vigilance is not a weakness, it is the mechanism. It is what keeps patients safe. So here is what I want you to carry with you into that room. The person standing beside you has spent years preparing for everything that can go wrong. They are not distracted. They are not indifferent. They are watching you with complete, undivided focus from the moment you close your eyes until the moment you open them again. You are not a number, not a time slot, not a case on a schedule. You are someone's reason to be careful. Yes, I am going to turn off your consciousness. I am going to paralyze your body and breathe for you and hold your life in the balance while a surgeon does something extraordinary inside you, and then I am going to bring you back. I have done it before. I am going to do it again. And I take that responsibility seriously in a way that repetition never diminishes, because no matter how many times you have done it, a life never feels routine.